I'm delighted to be here today to discuss my research related to urinary catheter self-management associated quality of life. Funding for my research has been supplied today through the United States National Institute of Nursing Research. Little research in urinary catheter self-management has been done. Self-management research, however, is much more common. Okay. Off to a good start today. Okay. In other chronic conditions, but not in people with catheters. Long-term catheter users often learn through trial and error, and they very often lack any support groups. Even people with multiple sclerosis who may be in a support group may not say anything to anybody else when they have a catheter because it's a stigma. It means that they're declining, their disease is getting worse. People are often told to drink, but they're not often told how much or how to manage that. This is a list of the typical catheter problems for both indwelling and intermittent catheter users, and you can see from both columns that the cavity and leakage are common to both. Balancing fluids with activity in catheterizations, however, is particularly important in IC users, intermittent catheter users, to prevent leakage or bladder over-distension and possible reflux. In one large study in Canada of people with spinal cord injury users of long-term catheters, intermittent catheters, cavity was higher in people who catheterized less often, and the highest incidence was in those who catheterized once daily. Blockage and frequent catheter changes are persistent problems in indwelling catheter users, and it can happen as often as several times a day and several times a week. Up to 50% of people with indwelling catheters are prone to regular blockage related to urea-splitting bacterial presence, which causes struvite and hydroxyapatite crystals, commonly known as crystals or sediment. Accidental dislodgement can affect people new to the catheter or those not aware or capable of noticing when transferring and making changes in the position in the bed or chair. Quality of life is often disrupted, in particular in people with long-term catheters, indwelling catheters. It can disrupt their daily routines and affects them, their catheter carers, and their families. I often heard this: it's okay when it's working right. When the catheter is working well, it seems to be in the background, like wearing glasses. You just don't notice them. But when it's causing a problem, it moves front and center and starts causing problems. One of my study participants, who I called Kevin, talked about getting wet while traveling on a bus, and he said, you really get soaked. He says it ruins the day. It ruins whatever you're driving in. Nurses and physicians in home care or clinics are the ones who have to help their patients troubleshoot or manage the catheter problems frequently during the evening and weekend hours. Thus, catheter problems often cause excess health care expenses. While we often think of this technology as simple or minor, it's not. And the choice of a suprapubic and a urethral catheter, which we've talked about a little today, should be something that's carefully considered between the provider and the family and the patient. Sexual activity can be more positive with the suprapubic, but not always. In fact, for some, bodily image is affected by placement of a suprapubic catheter. Some people who are no longer wet, though, look at the catheter as a benefit. And in one study, some catheter users, there was a study by Sarah Fowler, developed more self-reliance as they dealt with catheter problems. For others, an indwelling catheter was not so positive. For instance, it's often difficult to get bathroom access for emptying the bag, for people who have to plan accessible bathrooms for intermittent catheters, or even people with indwellings who need to empty that bag. And they have to adjust their outings or not go. Sometimes they end up being stuck at home. This is an overview of my research program showing how it was developed inductively. I've conducted 7 studies in people with indwelling catheters. All but one study, a chart audit, involved talking with patients who have catheters, and often their caregivers as well. I also conducted 2 studies in people with intermittent catheters and expanded my theoretical framework to them. This is a slide showing the analysis of data of 202 long-term indwelling catheter users who were in my recent self-management intervention study. They self-reported these problems for the previous 2 months prior to randomization for the trial including cavity, blockage, and accidental dislodgement. Additional data on leaking, sediment, twists and kinks in the catheter, bladder spasms, and autonomic dysreflexia indicate the catheter problems are frequent, even in just a 2-month period, and the data show that some people have to manage them as often as daily. You can see here we have the percent affected in a 2-month period and the rates, which is at the beginning of the study before we started the intervention. This slide also shows the extra healthcare costs associated with this 2-month period. And you can see that the costs are large with these catheter problems, particularly in those who need to be using the emergency room or the hospital. Notice also that the emergency department is not only used just for catheter changes and blockage and hospitalization, but also for unscheduled catheter changes. I was shocked to see that 31% had used the emergency department in a 2-month period. This figure has been published in an article in the American Journal of Nursing. It was created by Kara Tannenbaum, and it was first used in 2001 in an ICS workshop in Glasgow. The general self-management approach that we find is useful for physicians and nurses. Quoting from the article, self-management begins with a patient-identified problem, and an action plan is developed. The self-management behaviors that address the problem operate as if in a feedback loop, with patients becoming increasingly knowledgeable about their needs and strategies that work best for them as they come closer to attaining each goal. Self-efficacy is viewed as supporting self-management behaviors, and each in turn promotes self-efficacy. I'm going to switch now to tell you a little bit about the randomized trial of self-management in people with long-term indwelling catheters. And this is a list of our key colleagues. I worked with people at the Visiting Nurse Service in New York City who did 3/4 of the data collection, and also people in Central New York and University of Rochester, which is where I'm from. This is the model of the study, theoretically, and you can see how awareness and self-monitoring are parts of catheter self-management. That's how we view it that way. We believe this is an iterative process with self-management behaviors. We also believe there's a feedback loop with self-efficacy, similar to the previous diagram, as improved self-monitoring can increase confidence to self-management. And these are our outcomes: healthcare utilization, extra healthcare utilization, which I showed you in that other slide, and quality of life. The self-management intervention involved 4 contacts with a study nurse, 2 home visits a week apart in the first month, to teach the use of the urinary diary and to review the educational booklet. A follow-up telephone call was done 2 weeks later, and a final booster home visit at 4 months. Catheter users were taught to increase awareness and self-monitoring of their own patterns of urine flow, and to modify self-management behaviors as needed. We view self-monitoring as awareness and persistent observations or recordings. We had a 74% completion rate for the 12-month study. Attrition was similar in both arms. This describes the sample. We had similar numbers of men and women, a wide range in age, almost half with the suprapubic. And I've seen that in the last few studies, that more and more they're coming very close to even. The group was diverse by race, ethnicity. They were highly disabled. The CAT score was 7.75, and a score of 10 would mean needing assistance with all activities of daily living. Self-reported diagnoses related to having the reason for having the catheter were mostly spinal cord injury, 40%, multiple sclerosis, 23%, diabetes, 12%, prostate, 10%, and then a few other diagnoses. This is the catheter calendar, and this is rather important. It was used by both the intervention and the control groups to remind them for the bi-monthly phone calls for data collection with the interviewers, the trained interviewers, and they needed to know about what their catheter adverse problems were and the associated additional health care costs. So you can see there's a simple code here for each of the problems and a simple code for the treatments. This is our first page of our intervention booklet. Many people in my previous research had told me they did not know how much to drink. They were always told, drink, 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 but never understanding really what that meant. I noticed in a previous study that sometimes men would drink between 4,000 and 8,000 milliliters, and they did not know that was too much. So we taught people to be more aware of their own patterns and of fluid intake, and that it should be at an optimal and consistent level of fluid intake all day long. We estimated fluid requirements as about 30 milliliters per kilogram of body weight and calculated this for them, and we suggested that they can also use a very simple way of measuring fluid intake by looking at the color of the urine all day long. It should be light yellow. The other major part of the intervention was about preventing accidental dislodgement by preventing traction and kinks and twists, which could also affect the bladder and cause overdistension and increase their risk of CAUTI. These are tips and quotes that we shared from previous researchers, research quotes from my other studies, to help the participants learn through vicarious observation or learning from what others like them know, rather than just trial and error. It's also related to Bandura's theory about self-efficacy, and that was a foundation for the study. This is a quick guide to the problems and action strategies. We taught everybody to learn to pay attention to the fluids and to prevent dislodgement, but the study nurse also addressed other strategies based on the person's needs and interests. And they had a hard copy of the book in this study. This is one of the basic pages in our teaching intervention. This one's about fluids, and the nurse would now tailor the teaching to the person's needs instead of just saying drink lots of fluids. For instance, they might suggest drinking their water with a little bit of juice if they like it that, using cold water or warmer water, depending on the temperature. And then, of course, by watching the color of the urine. We also taught everyone to pay attention to their typical signs and symptoms of urinary tract infection. These are that I have listed are from our cross-sectional analysis at baseline, and I can tell you that it didn't change very much in the whole 12 months. I'm still analyzing data for the full study. Typically, it's the change in the color and the character of urine and some generalizable symptoms. Some of the others, the pain and the temperature, are a little bit less often. These are the main results from this trial. Urinary tract infection and dislodgement outcomes did not differ by group through GEE analysis. Blockage, however, was significantly lower in the intervention group, as reported as presence or absence during the bi-monthly phone call interviews during the first half of the study, but the result did not last for the full study of 12 months. The rates, however, give more information, and if you look at an article that was in the Nursing Research, you'll see the rates, because both groups did better, and the intervention group, compared with their baseline, had significant drops in the first 6 months, and that result held for the whole 6 months in terms of blockage. Everybody did better, though, on infection, blockage, and dislodgement, and hospitalizations. We have 2 rows of lines going down for both groups. The intervention group, however, did have more emergency department visits and hospitalizations for CAUTI and higher reported self-severity scores for their CAUTI. They may have actually had more infections and more severe infections. However, we were not powered for hospitalization. That would require a larger study. So the conclusion is that both groups improved over time, and a simple-to-use catheter problems calendar and the bi-monthly interviews might have functioned like a modest form of a self-monitoring intervention for controls. Blockage improved in the experimental group might have been related to the key fluid intake component of the intervention. And it's also not known whether this was truly of benefit, though, because the control group improved as well. Symptom identification, severity of UTIs, and getting care early could also be related to the more hospitalizations in the intervention group. So what we recommend is that there be more follow-up time with the intervention nurse to sustain the self-management intervention over time. there might be additional value in teaching related to optimal fluid intake, and we believe there is. Instead of saying just drink, drink, help them to learn how to do this. And this is based on research from Stickler and others, which you may have read about, in which the pH nucleation point, where the minerals drop out, is different than the pH in the urine if the urine is dilute, and if it's dilute all day long. So therefore, a catheter calendar, we believe, is a very simple form of an intervention, and it would be easy to implement. Patterns of catheter problems could also be more easily discerned, and we would recommend that their patients bring these calendars to their provider visits. The next study, which was also funded through the National Institutes of Nursing Research, is my current study. There are 3 articles on this. One about the intervention was just published a couple months ago in Urologic Nursing. The final one on the feasibility is in review, and the one on how it was developed is up on the website early. It's a listing of my colleagues in this study. A lot of IT people worked on this with me. First, I completed a qualitative study to identify the issues and concerns of intermittent catheter users as I prepared to extend the self-management theory and research process or design to people who are similar to indwelling catheter users, but we focused on people with spinal cord injury only. This is a brief list of the typical problems of people with intermittent catheters. Also, as in the Kelly study, I discovered that some people found pre-lubricated catheters hard to handle, and they would drop them in the bathroom. These are the aims for this study. First, it was a feasibility study to test the acceptability and usability of the website application. We tested the preliminary effectiveness of the intervention, and we developed and tested new measures of intermittent catheter self-efficacy and self-management. Overall, our goals were to try to help the patients learn to be more aware of their own patterns of intermittent catheterization, to obtain support and information for self-management, and sustain it over time. It was an intervention study with pre- and post measures. We were, again, teaching awareness, self-monitoring, and self-management, and we used a combination of web resources, including the ICI catheter products pages, which was used with permission, some additional catheter products which might be useful, such as insertion aids like the penis holder for men or leg spreader for women, and catheters attached to self-contained bags. I found in my qualitative study that a lot of people didn't have a clue about other catheters being available. This was 2008-9, and the change in the reimbursement and going from 5 catheters a month to 200 had just taken place, and some people didn't even know about it. There was also a 20-page web-based educational booklet based on my previous research and other literature, a new web-based urinary diary in I&O, which I'll show you soon, journal pages, and other, which I will show in screenshots. We had 3 phone calls with the study nurse over a 3-month period, discussion forums led by peers who had been involved in our initial development phase. There was 4 people with spinal cord for about 4 months, and 2 of them became the peer leaders. We also had the study coordinator, 2 doctoral students, and myself helping with that, with the forums. So this is a description of the sample. We had 30, but one person, I forget why, withdrew after the initial consent. Okay, that happens. They all had spinal cord injury, slightly more men than women. The mean and median ages were close, 44 and 47. The length of time using CIC was quite long, from anywhere from 1 year to 39 years, a mean of 16. The sample, again, was diverse by race and ethnicity, and their CAT score of 5.97 was quite a bit lower, meaning they were far more functional than the people with the indwelling catheters, which you would expect. All but one used a wheelchair. This is the first screenshot, and the top menu shows the sections of the intervention website with the ICI product website, commercial products, educational materials, etc., which is up here. And then the personal data sheet connects to these other links, the I&O, the journal, and then a chart, which actually is quite long, and I'll show you some screenshots of that. This page, however, is something that was recommended by the initial group, and it's a weekly pattern that they're supposed to write something in this little box. Not too many people did, but somebody who was an experienced guide suggested this. He works with other people with spinal cord injury. He said the weekend patterns are different than the week patterns, and if you have some difference about that, or some awareness of that, you might be able to better plan for your IC needs. There's a place to write and update goals, right here. This is an example of the I&O. These are all simulated data. And we also had an option of being able to choose some days. Maybe you'd want to choose just the Fridays and see if they're any different than the Mondays or the Tuesdays. You can see it's fluid intake here. The date and time are recorded. Urine output, leakage, color, mucus, blood clots, all those are yes, no, and a color is actually listed. And you can edit or delete them. And this gives you an idea of what the journal page was like. We recommended that people use a journal to get some sort of an idea of what's going on, especially if they're having a problem. The date and the time, again, are programmed right here to pop up. And we use these questions to sort of give people an idea of things that they might want to write about. But basically, it's the same pattern with what was noticed. In other words, what is the awareness? And then what did you do about it? One person said, for a new person, a journal like this would be an excellent because they have a basis then to go on from month to month, from year to year, of how they felt when they were sick, and if they had a CAUTI or anything. What we found is that there was a lot of variation in whether people used the journal. People did quite well with the 3-day I&O, and some people did many, many entries. So this is an example of the journal page. For instance, I was out and didn't cath enough that day, being busy, and have to change the behavior. Urine doesn't look right. Looking back at the list, I see my fluids had too much caffeine, trying for more water. This is the first of the overview page, and it's a summary. We displayed all the data in tables and graphs, and the color was supposed to be a little bit lighter yellow, but whatever. We wanted to have two different colors, so it's intake and output. This is another page from the summary table showing the charts that were give people kind of a snapshot on the dates. So you've got the intake and output here, the frequency, whether or not they had a journal intake, and then this is also a line graph to show people. Again, this is simulated data. The feasibility evaluation. The time here. Okay, this is. I'm going to summarize this. This is the last article, which would summarize this in that article. But several people were lost to follow-up early in the study, so only 26 of the 30 had their complete consultations with the nurse. The websites worked really well. The forums were liked by the people who used them. It was less than half, though. 10 out of 26 used them. And most of the posts were related to travel, insurance, medications, treatments for spinal cord injury. They liked the intervention, including the educational materials, the diary, the consultations, and discussion forums. The frequency in catheterizing to the desired frequency of 4 to 6 times a day had increased from 69 to 77%. It was not significantly different. Self-management, however, did increase significantly as measured by the new scale. Self-efficacy, quality of life improved, but not significantly over time. CAUTI, leakage, and pain all decrease, again, not significantly. The measures seem to perform adequately. They need further development in a larger sample, and they need more power. Fluid intake was the biggest self-management change based on interviews at the end of the study. And one person said, I'm probably more conscious of my intake of fluids than anything because I was one that really needed to do this, essentially. He said he was lazy, he slacked off, and after he talked with the nurse the second time, he cranked up his intake because he's not a water drinker, and now it's improved to drinking 36 ounces of water a day. and he cut out carbonated beverages. Sometimes they can irritate the bladder. I'm not sure why, but I've heard this for years. So we suggest a multi-site study in spinal cord injury units. Certainly in the U.S., we have quite a number of those. And you could focus on the people who are newly injured or people who are experienced, or in a combination, or looking at subgroup analysis with a larger study. You could do that. We recommend that you compare a paper and pencil diary to this web-based one. That could be another study. Cohort enrollments of about 10 would probably work better in forums. We also think that we needed more information on individual logins, actions taken by different people, so that we had a better idea of who participated and what they really got out of it more. Dissemination for education and research is now available because I'm retiring in May. And this is going to be, as soon as this last article's out, 3 articles for this study will be on the nurses' website for the International Continence Society, and you'll be able to see a link, information about getting in touch with me. I'm not just disappearing, so I'll be available. But our IT, our intellectual property, not IT, an IP department has contracts that they've developed, and they'll essentially be able to tailor it to your needs. And if you wanted to do this study, you can change anything you want, and we'll be able to track it over time. So that way, you're protected from liability. If you change something, we're protected from you if you change something, that kind of thing. And I feel very free then to share everything that was developed for this study. Some references.
Thank you very much, Mary.
Yeah, I know it took a little longer.
Yeah, we only have a couple minutes. Any comments or questions?
Okay, Catherine, I'll repeat what you said. Where do I see the gaps and where do I see research going? There's so many needs. I mean, I think that just thinking about all the different presentations that we've had, but what I think is needed, I think Diane identified a real gap in terms of very little information is known about people who use external sheaths, condom catheters. I think that's certainly needed. I think that more could be done in terms of fluid intake, and rigorous randomized trials could be done with that. But it's also a little bit difficult to control people's fluid intake. One of the recommendations was to try a citrated drink. I don't recommend that because I don't see how we could, as nurses, say, you need to drink this lemon drink. I mean, they did it for a week, and they had a washout period. But we're talking about a study where people need to make changes for indefinite periods of time. I think focusing on the population that really has the frequent problems with the UTIs or the blockage would be another way to change or to expand from here. I think we need a lot more research done on blockage.
I think, too, that we need a lot of research on practical use. I don't think we have any information on any catheters long-term. Go ahead, Sharon.
I think you're right, Diane. We have very little.
We think we know what people are doing, and we say we teach them that, but we have no idea, really.
Thanks, Mary, for this excellent work. Just to ask about the web-based program, could that be converted into an app?
Actually, I don't think I mentioned it. The diary is made into a mobile phone use adaptation.
Oh, right, good.
It's not a full app. I think it could be made into a full app. And the Cure UAB group, Cure Underactive Bladder group, they're interested in it from William Beaumont, and I probably will give them, because what the IT people who worked with us, they know about all these codes and things that were used in developing this, and they said they can just give it to people, and then they can do what they want with it.
I should tell you that WellSpec has a Stop UTI app. Has anybody gone on to that? Yeah, it's kind of neat. It's very simple, and it walks someone through what is an infection, what should be done, and I think we got to get more into apps. I do, because I could see where there could be. I don't know about you, but I have 3 daughters who don't even look at me anymore. They're always on their phone. Yeah. And I did a study in nurses at the University of Pennsylvania in the acute care on email, and they told me, can I get it on my phone? They don't look at email. Yeah. Everything is phone-based.
Right. This diary is really easy to use now. We had an extra $10,000 that was given to us, and it was earmarked then for making the change because it was our pre-testers who told us I'm lying down at bed at night and putting my legs up to deal with the fluid retention, and it's a little hard to use. And then they absolutely loved it when we made these changes for them. Because you can open, just like anything on a mobile phone, it opens up and you can move it around and easily use it. And you saw how many things are included in this diary. I've also noticed that there was a diary related to intermittent catheter use, but it was very simple. There was almost nothing to it.
Okay, well, thank you very much. We're out of our time. It's 12, but I really appreciate you coming, and hopefully we'll try to repeat this again sometime and change up.
Thank you for your attention.